Look down at your feet right now. If your ankles are puffy, if your shoes feel tighter in the evening than they did in the morning, if you press your finger into the skin above your ankle and the indentation stays there for a few seconds before it slowly fills back in, if you have been waking up with swelling that your doctor keeps calling fluid retention without ever explaining what is actually causing it or what to do about it, this video is for you. I am Dr. Amelia Carter. I work at the intersection of functional medicine and vascular biomechanics, which means I study not just what your body's symptoms look like from the outside, but what is actually happening inside the vessels, the tissues, the lymphatic channels, and the mechanical structures that either move fluid properly through your legs or allow it to pool there. Swollen feet, swollen ankles, swollen legs. The medical term is edema, and it is one of the most common complaints I hear from adults over 60. It is also one of the most dismissed. Told to elevate your feet, told to reduce your salt, told it is just part of getting older. It is not just part of getting older. It is a signal. And like every signal your body sends, it has a specific cause, and in most cases, a specific solution. Today, I am going to walk you through 9 distinct causes of lower leg and ankle edema. I am going to organize them from the most medically serious, the ones that require immediate attention, through to the most common, the one that in my clinical experience accounts for the vast majority of cases in otherwise healthy seniors. And for each one, I am going to tell you exactly what to look for, what it means for your body, and what the evidence says about addressing it. By the end of this video, you are going to understand your swelling in a way that your last appointment probably did not give you, and you are going to have a concrete, practical action plan that you can begin today. Before we go any further, the standard and necessary reminder: I am a doctor. I am not your doctor. Some of the causes of edema I am going to describe are medical emergencies that require immediate evaluation. I will be very clear about which ones those are. If anything I describe matches your symptoms closely, please contact your physician. Use this video to become informed, and then let that information guide you into the right conversation with the right medical professional. Let us begin. I want to start with a patient I will call Dorothy. Dorothy was 69 years old. A retired nurse from Tennessee, which meant she had spent 3 decades on her feet, walking hospital floors for 12-hour shifts, and she knew more about human physiology than most patients I see. When she retired, she started noticing something she had seen in patients for years but had never experienced herself. By 4 in the afternoon, her ankles were visibly swollen, her shoes felt tight. When she sat down in the evening and finally took her shoes off, the elastic band had left a deep indentation around her ankle that took 20 minutes to fade. She mentioned it to her physician at her annual physical. He checked her heart. He checked her kidneys. He told her everything looked fine and suggested she reduce her sodium. She reduced her sodium. The swelling continued. For 2 years, Dorothy adjusted her salt intake, elevated her feet in the evenings, and quietly accepted that this was simply what retirement looked like. She stopped wearing the shoes she loved because they were too tight by midday. She stopped going to evening events because her ankles looked embarrassing in dress shoes. Dorothy was not sick in the way her doctor was looking for, but she was not fine either, and the cause of her swelling, when we finally identified it, had nothing to do with her heart, her kidneys, her sodium, or her age. We are going to come back to Dorothy. But first, let me give you the full picture of what edema actually is and why your legs are the place it shows up first. Edema is the accumulation of fluid in the interstitial space, the tissue between your cells. In the lower legs and ankles, this accumulation is driven by a simple and relentless force: gravity. Your circulatory system works constantly to push blood upward from your feet back to your heart. Every beat of your heart sends oxygenated blood down through your arteries to your feet, and then, through the venous system and the lymphatic system, that blood and the fluid that surrounds your cells must be driven back upward against gravity, back to the heart, to the lungs, to be reoxygenated and sent around again. This upward journey is not passive. It requires the pumping action of your calf muscles. Every step you take squeezes the veins in your legs and propels blood upward. It requires competent one-way valves inside your veins, valves that open to let blood flow upward and snap shut to prevent it from falling back down. It requires adequate venous and lymphatic pressure gradients, and it requires a heart strong enough to create the suction at the other end that pulls blood back up into the central circulation. When any part of this system fails, when the pump is weak, when the valves are damaged, when the channels are blocked, when the pressure gradients are wrong, fluid accumulates where gravity deposits it, in the lowest point of the body, in your ankles, in your feet, in your lower legs. Understanding which part of the system is failing tells you exactly what the solution is, and that is what we are going to do today. Work through each failure mode systematically, from the most serious to the most common. The first cause is systemic cardiovascular and metabolic disease. This is where I always begin when evaluating edema in a senior patient. Because before we discuss mechanical causes and biomechanical solutions, we must rule out the causes that are signals of serious underlying disease. Congestive heart failure is the most critical of these. When the heart's pumping function is compromised, whether from previous heart attacks, from years of poorly controlled hypertension, from valve disease, or from other structural changes, the heart cannot create adequate suction to pull venous blood back from the periphery efficiently. Blood pools. Pressure in the venous system rises. Fluid leaks through capillary walls into surrounding tissue. It pools in the lowest gravity-dependent areas, your ankles, your feet. The edema of congestive heart failure has specific characteristics worth knowing. It is typically bilateral, both legs affected roughly equally. It tends to be worse at the end of the day and improves somewhat after a night of lying flat, when gravity is no longer pulling fluid into the legs. It is often accompanied by other symptoms: shortness of breath with exertion or when lying flat, unusual fatigue, reduced exercise tolerance, sometimes a persistent cough. If your ankle swelling is accompanied by any of these symptoms, particularly shortness of breath, this is a conversation that needs to happen with your physician promptly. Not eventually, promptly. Kidney disease is the second major systemic cause. Your kidneys regulate the body's fluid and protein balance with extraordinary precision. When kidney function is compromised, this regulation fails in two directions. First, the kidneys may retain sodium and water that should be excreted, directly increasing fluid volume and pressure throughout the circulatory system. Second, damaged kidneys may allow albumin, a large protein that normally stays in the blood, to leak into the urine. Albumin in the blood creates what is called oncotic pressure. It acts like a sponge, drawing fluid from the surrounding tissues back into the bloodstream. When albumin leaks out through damaged glomeruli, this osmotic pull is lost. Fluid that should be drawn back into the circulation stays in the tissue. Edema results. The edema of kidney disease can look very similar to cardiac edema. Bilateral, gravity-dependent, worse with prolonged standing. A simple urine test checking for protein, specifically a urine albumin to creatinine ratio, which we discussed in detail in a previous masterclass, can identify kidney-related protein leakage. Chronic liver disease affects the body's albumin production. The liver manufactures albumin, and a failing liver produces less of it. The same loss of oncotic pressure results. Fluid that should stay in the circulation leaks into surrounding tissue. Long-standing, poorly controlled diabetes affects the vascular system throughout the body, including the capillaries and small vessels in the legs, in ways that compromise fluid management at the microvascular level, and significant obesity places chronic mechanical and cardiovascular stress on every fluid management system simultaneously. Increased central venous pressure, reduced mobility of the calf muscle pump, and often concurrent metabolic conditions that compound the problem. If you have any of these underlying conditions and you have edema, the edema is a signal of how well or how poorly the underlying condition is being managed. Addressing the edema without aggressively managing the underlying condition is treating the shadow rather than the object casting it. Please see your physician. And if your physician is not connecting your edema to your underlying conditions and actively managing both, ask them directly why. The second cause is medication-induced edema. This one is underappreciated and critically important for seniors because the class of medications most commonly responsible for drug-induced leg edema is one of the most widely prescribed blood pressure medication classes in the world. Calcium channel blockers, and I want to be careful here to speak to mechanism rather than to alarm, work by relaxing the smooth muscle in the walls of arteries, causing them to dilate and blood pressure to drop. The specific mechanism involves the precapillary arterioles, the tiny arteries feeding into the capillary beds, which open wide under the drug's influence, but the postcapillary venules, the tiny veins draining the capillary beds, are not similarly affected. They remain at their resting tone. The result is a pressure imbalance inside the capillary bed. Blood is being pushed in faster than it can drain out. The hydrostatic pressure inside the capillaries rises. Fluid is squeezed through the semi-permeable capillary walls into the surrounding tissue. Ankle edema. This edema is not a sign that your heart is failing. It is not a sign that your kidneys are struggling. It is a mechanical consequence of a drug-induced pressure mismatch in your microvascular architecture. At standard doses, research suggests that between 3 and 30% of patients on this medication class develop ankle edema, with women experiencing higher rates than men. At higher doses, the rates increase substantially. What makes this particularly problematic is the prescribing cascade it triggers. Your doctor sees swollen ankles and adds a diuretic, a water pill, to remove the fluid. The diuretic depletes potassium and magnesium. Now you are on two medications, the second treating a side effect of the first while creating its own mineral depletion side effects. And because the underlying pressure mismatch in the capillaries has not been corrected, the fluid continues to accumulate as fast as the diuretic removes it. If your ankle swelling began or worsened after starting a blood pressure medication, and if you are on a medication in the calcium channel blocker class, this specific connection is worth raising with your prescribing physician. Ask whether the swelling predates or postdates the medication. Ask whether an alternative class, particularly an ARB, might manage your blood pressure equivalently without the capillary pressure mismatch mechanism. Do not stop any medication without speaking to your physician first, but do have the conversation. The third cause is lymphedema. The lymphatic system is the body's secondary fluid management network. While the venous system carries blood back to the heart, the lymphatic system collects the larger protein molecules and fluid that leak from capillaries into the surrounding tissue in the normal course of circulatory function and returns them to the bloodstream through a network of lymph vessels and lymph nodes. When the lymphatic vessels are damaged by genetic factors, by chronic obesity that compresses and stresses lymph channels over years, by repeated skin infections like cellulitis, by injuries, or by certain medical procedures, they lose the capacity to drain this interstitial fluid effectively. It accumulates. The tissue becomes chronically swollen. Lymphedema has specific characteristics that distinguish it from venous edema. The swelling tends to be firmer to the touch, not as pitting, because the accumulated fluid contains higher protein concentrations that eventually stimulate a fibrotic tissue response. The skin over affected areas can develop a thickened, rough texture with time, in advanced cases resembling tree bark, a finding clinicians call papillomatosis. The swelling in lymphedema does not improve as dramatically with elevation as venous edema does, because the problem is not simply hydrostatic pressure. It is a drainage system that cannot function. Lymphedema is a chronic condition that requires specific management, compression therapy, specialized lymphatic drainage techniques, and in many cases, a referral to a lymphedema therapist who specializes in this area. If your swelling has the firmer, non-pitting quality I described, if the skin texture has changed, and if elevation does not provide significant relief, please discuss lymphedema specifically with your physician. The fourth cause is venous insufficiency and varicose veins. This is an extremely common cause of lower leg edema in older adults, and it deserves careful attention because it is both frequently underdiagnosed and very responsive to the right interventions. Your leg veins contain one-way valves. thin leaflets of tissue that open to allow blood to flow upward toward the heart and snap closed under the backward pressure of gravity to prevent blood from falling back down. These valves are mechanical structures, and like all mechanical structures, they wear with time and use. When the valve leaflets become stretched, weakened, or damaged from genetics, from years of prolonged standing, from pregnancy, from obesity, from a history of blood clots, they no longer close completely. Blood that has traveled upward against gravity falls back downward when the valve fails to close. It pools in the vein below the damaged valve. The vein stretches under the accumulated pressure. In superficial veins, this stretching becomes visible at the skin surface as the twisted, ropey, bluish-purple structures we call varicose veins. In deeper veins, the same process occurs invisibly but with consequences that are felt as chronic heaviness, aching, and swelling in the lower leg. The edema of venous insufficiency has a characteristic pattern. It is typically worse at the end of the day after prolonged standing or sitting, and improves significantly, often dramatically, after a night of lying flat with the legs at heart level. The skin over the lower leg may develop a brownish discoloration over time from the chronic leakage of red blood cells into surrounding tissue, a finding called hemosiderin staining. In more advanced cases, the skin can become thick, indurated, and prone to breakdown. The single most effective first-line intervention for venous insufficiency edema is graduated compression. Medical-grade compression stockings, typically at 20 to 30 mmHg of pressure for mild to moderate venous insufficiency, apply external graduated pressure to the leg, highest at the ankle, and decreasing up the calf, that supplements the failing valve function by preventing blood from pooling in the distended veins. I want to be specific about this because the difference between properly fitted medical-grade compression and the loose flight socks sold at pharmacies is clinically meaningful. Properly fitted compression stockings are measured to your specific leg circumference and length, apply a calibrated pressure gradient, and should be put on in the morning before you get out of bed, before gravity has had time to fill the veins. If you are putting them on after you are already swollen, you have already lost the most important window. For those with more significant venous disease, larger varicosities, chronic venous stasis changes in the skin, a consultation with a vascular specialist is appropriate. There are minimally invasive procedures that can close incompetent veins effectively and safely, and the technology has improved dramatically in recent years. The fifth cause is deep vein thrombosis. I am going to spend careful time here because this is the cause of lower leg swelling that requires the most urgent attention and the most important recognition. A deep vein thrombosis, DVT, is a blood clot forming inside the deep venous system of the leg, most commonly in the calf. It is a medical emergency that requires prompt diagnosis and treatment for two reasons. First, the clot causes local obstruction. Venous blood cannot flow past the clot. Pressure backs up behind it. Fluid leaks into the surrounding tissue. Swelling occurs. The leg may feel tight, heavy, and painful, often described as a deep cramping or aching sensation that does not go away with elevation or rest. Second, and more critically, a clot in the deep leg veins can break free from its attachment to the vessel wall, travel upward through the venous system, pass through the right side of the heart, and lodge in the pulmonary vasculature, the blood vessels of the lungs. This is a pulmonary embolism. A large pulmonary embolism can be fatal within minutes. The signs that should prompt you to seek immediate medical evaluation, not your next scheduled appointment, but today, now, are these. Swelling that is unilateral, affecting one leg significantly more than the other, particularly if it developed over hours rather than days. Warmth and redness in the affected leg, the calf or the thigh feeling noticeably warmer to the touch than the other side, possibly with visible redness or discoloration. Pain on squeezing the calf, tenderness that is present even at rest and intensifies with gentle pressure on the calf muscle. Any combination of these findings warrants emergency evaluation. A venous Doppler ultrasound, a non-invasive imaging study, can identify a clot with high accuracy and takes less than an hour to perform. If a clot is confirmed, anticoagulation therapy is started immediately to prevent propagation and embolization. The risk factors for DVT that are most relevant to seniors include recent surgery, particularly hip or knee replacement, which carries particularly high DVT risk, prolonged immobility such as a long flight or a period of bed rest during illness, a personal or family history of blood clots, active cancer, and certain medications. If any of these risk factors apply to you and you develop sudden asymmetric leg swelling with warmth and tenderness, do not wait. Seek evaluation today. The sixth cause is infection. Localized infection in the foot or lower leg can produce significant swelling through the inflammatory response, increased blood flow, increased capillary permeability, and fluid accumulation in the infected tissue. The swelling of infection is typically unilateral, localized to the area of infection, and associated with other inflammatory signs: warmth, redness, tenderness, and sometimes fever or systemic unwellness. Cellulitis, a bacterial skin infection, is the most common infectious cause of leg swelling in older adults. It can develop from a minor break in the skin that may not be immediately obvious: a small cut, a crack between the toes from athlete's foot, an insect bite, an area of dry, cracked skin. In people with diabetes or poor circulation, even minor skin breaks can become entry points for bacterial infection, and the immune response that follows can be vigorous. The warning signs that indicate an infection rather than a fluid management problem are directional. The swelling is in a clearly demarcated area, not diffuse throughout both lower legs. The skin over the swollen area is red and warm. There may be visible streaking, a red line extending from the swollen area up the leg, which represents spread of infection along the lymphatic channels and warrants immediate evaluation. There may be a visible wound, ulcer, or break in the skin at the center of the swelling. If you have any break in the skin of your foot or lower leg that is red, warm, enlarging, or painful, or if you have any open wound that is not healing normally, please contact your physician. In people with diabetes or compromised circulation, foot infections can escalate rapidly and require prompt antibiotic treatment. The seventh cause is edema secondary to blood pressure medication. Specifically, I want to address this separately from the calcium channel blocker mechanism we discussed earlier because there is another class of medication effect worth understanding. Some seniors are started on diuretics, water pills, specifically for edema, without full investigation of the underlying cause. The diuretic produces temporary improvement in swelling by forcing the kidneys to excrete more sodium and water. But if the swelling is not caused by fluid overload from cardiac or renal disease, if it is from venous insufficiency or from a calcium channel blocker or from the mechanical causes we are about to discuss, the diuretic is treating the symptom rather than the mechanism. The fluid returns as soon as the diuretic effect wears off, and meanwhile, the diuretic is depleting potassium and magnesium, with consequences we have discussed in detail in earlier masterclasses. If you have been placed on a diuretic for leg swelling and the cause of that swelling has never been specifically evaluated, if your doctor simply prescribed the diuretic to treat the edema without investigating whether it came from venous insufficiency, from medication side effect, or from another cause, that evaluation is worth requesting. The eighth cause is prolonged immobility and sedentary behavior. This is where we begin transitioning from the medically dangerous causes toward the most common causes and the most correctable ones. Your calf muscles are not simply locomotion engines, they are the second heart of your lower body. Every time your calf contracts, every time you take a step, rise on your toes, walk up a stair, it squeezes the deep veins of the leg and propels a bolus of venous blood upward toward the heart against gravity. The one-way valves in the veins then hold that blood in place until the next muscular contraction sends it further upward. This calf muscle pump is responsible for a large proportion of venous return from the legs. Without it, the heart alone cannot overcome gravity efficiently enough to prevent fluid from pooling in the lower extremities. When you sit for 4, 6, 8 hours in a recliner at a desk on a couch watching television, the calf muscle pump is inactive. Blood pools in the lower leg veins, pressure rises. Fluid leaks into surrounding tissue. By the end of a long day of sitting, the swelling is visible. This is not disease. This is physics. Gravity versus an inactive pump. The intervention is correspondingly direct. Movement, not intense exercise. Movement. Breaking up long periods of sitting with brief periods of activity every hour, even just standing, walking to the kitchen and back, marching in place for 2 minutes, reactivates the calf muscle pump and mechanically drives the pooled venous blood back upward. For those with limited mobility, seated calf raises, lifting your heels off the floor while seated repeatedly, activating the calf muscle without bearing weight, provide meaningful venous pump activation even from a chair. Ankle circles, flexing and pointing the feet, and gentle seated leg exercises all contribute. The principle is simple. The calf pump must be used to work. Any movement is better than continued stillness. And now we arrive at what I believe is the 9th cause. And in my clinical experience with active, otherwise healthy seniors, the cause that accounts for the largest proportion of unexplained lower leg and ankle swelling. The cause that most closely matches Dorothy's story. The cause that has nothing to do with disease and everything to do with mechanics, postural asymmetry, and musculoskeletal restriction. I want to take time here because this is the cause that is most consistently overlooked and most consistently correctable. And it connects to a fundamental truth about how the aging body moves that most people have never had explained to them. Your feet are the foundation of your entire mechanical system. When you walk, the way your foot contacts the ground, absorbs shock, and transfers force determines the demands placed on every joint above it: your ankle, your knee, your hip, your lower back. And the way your foot functions is determined by the flexibility and balance of the muscles that control it. The most clinically important measurement in this entire picture is something called dorsiflexion range of motion. Dorsiflexion is the movement of bringing the top of your foot toward your shin, the ankle bend that occurs with every step you take as your body's weight moves forward over your foot. A healthy ankle should dorsiflex at least 10 to 15 degrees beyond neutral. This range of motion is what allows your calf muscles, your Achilles tendon, your plantar fascia, and the small intrinsic muscles of your foot to absorb the mechanical load of walking efficiently and symmetrically. When the calf muscles and Achilles tendon are chronically tight, which is extremely common in older adults who have spent decades in heeled shoes, who have reduced their physical activity, or who have never specifically addressed lower leg flexibility, dorsiflexion range decreases. The ankle cannot bend far enough forward during the stance phase of walking. The body compensates. To keep moving forward when the ankle will not bend enough, the foot pronates, the arch collapses inward, and the foot rolls to the inside. This pronation allows the body to continue forward, but it places abnormal mechanical stress on the tendons along the inside of the ankle, the small joints of the midfoot, and the plantar fascia. Now add to this picture what happens when there is asymmetry between the two sides, one ankle slightly tighter than the other, perhaps from an old ankle sprain, from a difference in how each leg has been loaded over decades, from a subtle leg length difference. The body compensates differently on each side. The pelvis tilts, the lower back muscles work asymmetrically, the gait pattern becomes uneven. In an uneven gait, the lower leg muscles on the tighter, more compensated side are working harder with every step. They fatigue more rapidly. Blood flow to the working muscles increases disproportionately, and the pump efficiency is reduced because the compensated mechanical pattern does not activate the calf pump as effectively as a symmetrical, efficient gait does. The fluid accumulates preferentially on the more affected side, or bilaterally if the restriction is bilateral, as it often is. This is not disease. This is a mechanical efficiency problem, and it is entirely addressable. The first step is honestly assessing your own ankle flexibility. Sit in a chair and try to pull the top of your foot toward your shin. Note how far it moves. Now do the other side. Is one side stiffer than the other? Does one side feel like it has a firm stop earlier than the other? That asymmetry, that difference, is the mechanical imbalance that may be driving your swelling. The second step is addressing calf and Achilles tightness through consistent, progressive stretching. The most effective stretch for the calf and Achilles complex is a standing wall stretch. Place both hands on a wall, step 1 foot back, keeping the heel firmly on the floor and the knee straight. Lean your body weight gently forward until you feel a stretch in the back of the lower leg. Hold for 30 seconds. Repeat 3 times on each side. For the deeper Achilles and lower calf, the same stretch performed with the back knee slightly bent targets the soleus muscle specifically. The important caveats are these: warm the tissue before stretching. A 5-minute walk, gentle ankle circles, or even a warm shower prepares the tissue for lengthening more effectively and more safely than cold stretching. Never stretch into sharp pain, and consistency over weeks and months produces the lasting change. One day of stretching does not undo years of tightness. A graduated ankle stretch board, a wedge-shaped platform you stand on to progressively increase the stretch angle, allows you to systematically increase the range of motion challenge over time in a controlled way. Starting at 15 degrees and progressing gradually as flexibility improves is an evidence-supported approach to restoring dorsiflexion range in adults. The third step is addressing the shoe environment, the heel-to-toe drop in your footwear. The difference in height between the heel and the forefoot profoundly affects how much your calf muscles and Achilles tendon must lengthen during walking. A significant heel rise allows you to walk without fully stretching the calf complex with each step. Over years, the tissues adapt to this shortened position. When you then walk in flat shoes or barefoot, the shortened tissues are placed under sudden increased demand and complain. A shoe with appropriate cushioning, a moderate heel-to-toe drop, and a firm heel counter that prevents the foot from rolling excessively provides a mechanical environment that supports the foot and reduces the demand on the small intrinsic muscles while the larger calf and hip muscles do their appropriate share of the work. For adults with significant swelling and significant foot mechanics issues, a supportive shoe combined with a properly fitted orthotic insert, one that controls excessive pronation without rigidly preventing all natural foot motion, reduces the mechanical compensation load and allows the calf pump to function more efficiently. The fourth step is targeted self-care for the tight, overworked muscles. Calf rolling with a foam roller or a simple massage stick, applying gentle, sustained pressure along the length of the calf muscle while slowly moving the roller from ankle to knee, provides myofascial release to chronically tight tissue. The pressure does not need to be aggressive or painful. Gentle, sustained contact allows the tissue to release over time. 3 to 5 minutes per leg before and after activity or in the evening before bed is a sustainable and clinically meaningful practice. Cold therapy, a frozen water bottle rolled under the sole of the foot, or an ice pack applied to the calf, reduces local inflammation and can provide significant symptomatic relief, particularly in the evenings when swelling is at its peak. Elevation, lying with the feet raised above the level of the heart for 20 to 30 minutes, assists passive venous drainage and provides temporary reduction in edema. The important qualification is that elevation relieves fluid that has accumulated. It does not address the cause of accumulation. It is a symptomatic measure, not a solution. Now let me tell you what happened to Dorothy. When I reviewed Dorothy's history, the pattern was clear. Her swelling was bilateral, worse at the end of the day, improved substantially with elevation and with a night of sleep. Her heart function was normal, her kidney function was normal. She was not on a calcium channel blocker. She had no history of blood clots. No skin changes suggesting lymphedema, no infection. What she did have was a history of 40 years of professional nursing, decades of standing and walking on hard hospital floors, often in inadequate footwear. Tight calf muscles, reduced dorsiflexion on the left side compared to the right, a subtle left-sided limp that she had developed so gradually she was no longer aware of it, but that was visible on casual observation. She had venous insufficiency, mild from years of prolonged standing, compounded by chronic calf tightness that was reducing the efficiency of her calf pump and placing excessive mechanical load on the small structures of the foot and ankle. We started with fitted compression stockings, 20 to 30 millimeters of mercury, worn from rising until she put her feet up in the evening. We began a structured daily calf stretching program. We addressed her footwear. We started simple calf rolling twice daily. At her follow-up appointment, Dorothy looked at me and said something I want you to hear. She said, "For 2 years, I thought this was just aging. Nobody told me there was something I could actually do about it. There is something you can actually do about it. Let me close with your complete action plan. Organize clearly so you can begin applying it today. Step 1. Rule out the serious causes first. If your swelling is accompanied by shortness of breath, chest discomfort, or dramatic sudden worsening, see your physician urgently. If one leg is significantly more swollen than the other, especially with warmth and tenderness, seek evaluation for DVT today. If you have visible skin changes, open wounds, or redness spreading from a wound, contact your physician promptly. Step 2. Review your medication list. If you are on a calcium channel blocker and your swelling began or worsened after starting it, discuss this specifically with your prescribing physician. Ask about alternatives. Do not stop the medication on your own, but have the conversation. Step 3. Address the calf pump. Break up long sitting periods every hour with at least 2 to 3 minutes of movement. Seated calf raises and ankle circles when standing is not possible. This is the single most accessible and most immediately effective intervention for sedentary edema. Step 4. Begin a daily calf and Achilles stretching program. Wall stretches, 30 seconds, 3 repetitions, each side, every morning after a warm-up. Consistency over weeks produces lasting flexibility improvement. Step 5. Assess your footwear. A supportive shoe with appropriate cushioning, a moderate heel-to-toe drop, and a firm heel counter is not optional for someone managing lower leg edema. A properly fitted orthotic insert from a podiatrist or physical therapist can address specific mechanical compensation patterns that your standard footwear does not correct. Step 6. Use compression. Medical-grade graduated compression stockings, properly fitted, worn from rising to evening. For mild to moderate venous insufficiency, 20 to 30 millimeters of mercury. Put them on before you get out of bed in the morning, before gravity fills the veins. Step 7. Add daily soft tissue work. A foam roller or massage stick on the calf muscles and hamstrings for 3 to 5 minutes per side, once or twice daily. Gentle, sustained, consistent. This is not a treatment you do once when things are bad. It is a maintenance practice, like brushing your teeth. Step 8. Get a biomechanical assessment. A podiatrist or a physical therapist can evaluate whether asymmetry between your two sides, one ankle tighter, one hip higher, one knee tracking differently, is contributing to your swelling and your discomfort. This kind of assessment typically takes 1 or 2 appointments and can reveal patterns that have been loading your body unevenly for years. Swollen feet and ankles are not simply the price of getting older. They are a signal. Some of those signals are urgent and require immediate medical evaluation. Some are correctable with targeted lifestyle and mechanical interventions that cost nothing and begin working within days. Dorothy understood her body better after one conversation than she had from 2 years of being told to reduce her sodium. That understanding gave her back the shoes she loved and the evening events she had stopped attending. You deserve that same understanding. I am Dr. Amelia Carter. Take care of your body. Take care of the systems that carry you through every day of your life. I will see you in the next video.